going through the kind of evaluation outcomes of our project that we kind of did in the Scottish Borders. So my name's Jen Grant. I'm the dietitian with Food Train and Eat Well, Age Well, and I'm joined this morning with Eleanor Coleman and Gemma Hawkins from our kind of first team in Decipher that helped us with our evaluation. They can kind of give you a wee bit more of a bio of themselves when they chat. We've also got Michael Curran here from the Scottish Borders Health and Social Care Partnership as well. So as I say, we'll just this morning be kind of, or this afternoon, I should say, we'll just kind of be taking you through a wee introduction to the project and the Patients Association Nutrition Checklist. Gemma will give us a wee bit more information about NIHR and FIRST, and then we'll hand over to Eleanor, who will kind of take us through the evaluation of this project and our findings from the evaluation. We'll also have a wee bit of time at the end for any kind of questions that you might have. Feel free just to use either the chat, or we've got the wee Q&A function enabled where you can just pop your questions in as we go, and then we'll just kind of go through them at the end. Like I say, this session is being recorded, so you'll get a wee link afterwards to the recording. So if you kind of have to miss any wee bits or that, that'll kind of get you going. So I'll just crack right into it. So I'm just going to take us through excuse me, I'm just going to take us through the first wee section with just a wee overview of the project and what we were doing. So like I say, I'm the dietitian with Food Train and Eat Well, Age Well, and we are a Scottish charity that kind of primarily provides services to older people around kind of shopping services and just general kind of day-to-day help who are maybe not able to manage through maybe age, ill health, frailty, disability, that kind of thing. And Eat Well, Age Well is a project within Food Train that was set up to contribute to the kind of prevention, detection and treatment of malnutrition amongst older adults living at home in Scotland. We were set up sort of 5 years ago now, actually, on the back of some work that had been done around Food Train within the kind of the staff, the older people we were working with, and kind of various stakeholders, where there wasn't really a great resource around malnutrition. There wasn't really a great support for people. So over the last few years, we have been trying various bits and pieces of work to aid that kind of prevention, detection and treatment of malnutrition. And that's really where this project started. So as you might know, around 1 in 10 older adults are thought to be at risk or suffering from malnutrition. And it's something that there's been a really kind of inconsistent approach to tackling this issue. We know that there's, a lot of great work going on in the health service around MUST, a lot of people using different tools and different ways to identify people who are at risk of malnutrition, but not really a great sort of consistent approach across different organisations, and it can be really variable within sort of social care and third sector settings. So in the last sort of few years through Eat Well, Age Well, we've had a lot of good results from implementing a new tool, the Patients Association Nutrition Checklist, in kind of various social care and third sector organisations across Scotland. So we were getting a lot of good results back from these kind of individual projects, but again, we were kind of noticing that these bits of good practice are happening kind of really disjointed across Scotland. No one's really taken that sort of consistent approach. We weren't sure if that's something that would even work. But we had kind of noticed that there wasn't really that kind of great link where everybody was doing their own sort of thing, and that was leading to, a lot of confusion about what people do, a lot of confusion around, if you identify somebody that's at risk of malnutrition, what do you do with them? How do you support that person? If you then kind of refer them to another organisation, will that organisation pick it up and things like that? So we were looking for a way to kind of improve that and see if we could introduce a wee bit more of a consistent approach and if that would have kind of benefits. So we did that. As I say, we did a lot of work with the Patients Association Nutrition Checklist, and that's the kind of angle that we took through this project in the Scottish Borders. we were using the Patients Association Nutrition Checklist, which I'm just going to start calling the checklist from now on, because it's a bit of an easier mouthful to say. So if you don't know kind of much about the checklist, it was developed by the Patients Association and launched in 2018. And it is very much what it says on the tin, that it is a checklist about someone's nutrition. And it was designed as a kind of simple way to identify older people that might be at risk of malnutrition. It is kind of broken into different sections, but your kind of main section is section A, which is just 4 initial questions designed to identify whether or not someone could be at risk of malnutrition. So ask questions around weight loss, around appetite, whether clothes and shoes and jewellery still fit, and whether there has been any kind of patient or family concern about that person's diet or nutrition. If somebody answers yes or they don't know to any of these 4 questions, they're considered to be at risk of malnutrition and can then use the rest of the checklist to kind of identify other kind of underlying issues, to get a bit of signposting, a bit of first line advice. It's a really kind of easy to use tool. It's easy to implement, and it can just be a great wee conversation starter in getting people to chat about malnutrition, chat about people's diet, and identify early on if there's a problem. So like I say, we'd had some really kind of good success across a lot of different organisations. So we had sort of aimed with this project in the Borders to test a sort of a larger scale rollout of that checklist and that implementation of a more consistent approach across a sort of a geographical area, and how that might affect the kind of prevention, identification and treatment of malnutrition. So we were really grateful to be able to work with the Borders Health and Social Care Partnership. They were really keen to let us try this idea, and we were able to then work with key members of staff within the Health and Social Care Partnership to establish a wee delivery group and identify kind of key organisations that were working with older people. So that was both in sort of health, social care and the third sector as well. So within the delivery group, we then kind of had a lot of great discussion about how a project such as this would roll out. We elected to focus on more of the kind of social care and third sector organisations, because there was already pathways in place, there was already processes in place within the health service to identify malnutrition risk and kind of do something about it, but there wasn't so much that approach within the social care and third sector organisations. So like I say, we worked with that delivery group to identify kind of key organisations. We also worked with the local dietetic services to ensure your kind of onward referral pathways fit in with what the existing referral pathways. So we wanted this approach to really kind of streamline in with what people were already doing. So in the kind of the bare bones of it, if you like, we identified these organisations across social care and the third sector. So these were organisations like housing, home care organisations, various kind of community support and day centres, things like that, that were working with older people already. They kind of had those relationships. They were seeing them maybe, day to day, week to week, and had that kind of contact with them. We then worked with the individual organisations to embed the checklist into their existing processes. So this looked kind of different depending on the organisation, but the general idea was that we were implementing the checklist as a kind of a regular way to be used with older people they were working with, and to identify people that might be at risk of malnutrition and kind of do something about that. So we had set up kind of a general pathway where people would be, people would use the checklist with the older people they were working with. If they were kind of identified to be at risk, they would give a bit of first line advice and then follow that person up within the bounds of their kind of service. Should they then need further information or further support, then they could be referred on to kind of the local dietetic services in line with their existing referral pathways. We at Eat Well Age Well provided the kind of staff training around sort of malnutrition using the checklist and first line advice, so that all the staff that were kind of using the checklist and were implementing this project were kind of up to speed and were all on the same kind of skill level and could feel a bit more confident, hopefully, about kind of providing a bit of first line advice and supporting people who could be at risk of malnutrition. So that is the kind of the whistle stop tour of the project. I'm going to hand you on to Gemma just now, who's going to give you just a wee bit about our logic model that was developed, and then on to a wee bit of background around FIRST and NIHR as well.
Hi everybody, and thank you, Jen. So as Jen said, this is what we call our logic model. So essentially, as it says on the screen, it's a visual depiction of the checklist and what it's intended or hoped to do. So I appreciate this is probably quite small writing, but we're going to share with you a link to our full report at the end of the webinar, and you'll be able to see this in much more detail and larger text. But essentially what this shows us is across the top of the 4 columns, you can see the headings there: inputs, activities, and outcomes. And what we're trying to show here is the inputs that we think are needed for organisations that Jen was just talking about to be able to implement the checklist in their practice. What is needed to make that happen? And then in terms of activities, what actually needs to take place for implementing the checklist? And then what outcomes, both short-term and long-term, do we hope to be realised as a result of using the checklist in various different health and third sector organisations? So there's 3 different rows here, and the bottom row that's in kind of a blue colour is what we expect to see happen for older people when the checklist is used with them in practice. So this is what we would hope would happen when the checklist is used, and then what outcomes we would see. But what we've also included there in the red middle section is what is needed for the staff and volunteers at these organisations to be able to use the checklist in their everyday work. So thinking about what training is needed and what the outcomes of that training would hopefully be, which, as Jen said, was provided by Eat Well Age Well. But also then at the very top in the green kind of colour is what needs to happen in those organisations as well to support the staff and volunteers to implement the checklist, to be able to use it properly. So what's needed to embed that, as Jen was talking about. And essentially, by creating this logic model, it helped us to think about, when we first designed the project, what things do we need to explore and try and understand when we try to evaluate this rollout of the checklist in Scottish Borders. So this was something that we worked together on to co-develop this diagram that kind of provided a shared understanding of everybody working on the project. We'll tell you a little bit more about the project shortly, but firstly, I just wanted to tell you a bit about what NIHR is and what FIRST is. So we heard these acronyms right at the start, and I just wanted to give a little bit of an overview of what they are. So you can see on this slide at the top here, I've got 2 logos. So one of them says NIHR Public Health Intervention Responsive Studies Teams, and then the one next to it says NIHR National Institute for Health and Care Research. So essentially, the NIHR is a UK funding body that funds research into health and care outcomes. So its focus is to try and improve the health of the population through robust pieces of research that helped us to know what things help bring about improvements in health and what things to avoid doing. So Jen mentioned FIRST, which is PHIRST, and that stands for Public Health Intervention Responsive Study Teams. It's a very long word description, and that's why we call it FIRST for short. It essentially is a research initiative that was set up in 2020 and is funded by the NIHR with the focus, or with the goal, of helping to evaluate public health interventions that are taking place across the UK being run within local authorities, just like the implementation of the Patients Association nutrition checklist that Jen was talking about. So there are 6 FIRST teams across the UK, and myself and Eleanor, we work for one of the teams that's based across Bristol and Cardiff. It's called First Insight, but there's 5 other teams as well. And essentially we're there to help provide some scientific and research support to conduct evaluations. So myself, I'm a researcher that works in Cardiff University. I've been working on public health research for 10 years. Eleanor will introduce herself shortly, but again, has a lot of research experience. So local authorities can apply to have their intervention evaluated with the support of a FIRST team. And the idea of the evaluations is that they can be done in a timely way to provide very accessible information and useful information to the local authorities that apply. And the focus of the interventions, the initiatives, need to be on improving health and reducing health inequalities. So what happened with the Eat Well, Age Well project was that Jen and colleagues in the Scottish Borders applied to have an evaluation done of the rollout that Jen was just describing. They got shortlisted to be evaluated, and they were allocated to the First Insight team that myself and Eleanor work on. So then myself and Eleanor within our FIRST team were allocated to work with the team in Scottish Borders. So the idea is that together with the local authority stakeholders and organisations, with the research team in FIRST, and with representatives of the public, we co-design the evaluation to make sure that it's really focusing on the most important things. So you can see at the bottom of the slide there, this is something that happens a couple of times a year. So the next call for applications closes on the 26th of September, and the web link is there to find out more information. And the next slide just shows you what that website looks like. So it's got quite a lot of information about how FIRST is useful for health and care professionals, of our partnerships with the public, and further down that page is where you can find information about the application. But if you click on evaluations, you can see on the top there, that will tell you about all the current evaluations that are taking place, including the one that we're talking about today. So I'm going to hand over to Eleanor now, who's going to talk to you about the design of this evaluation of the Eat Well, Age Well rollout of the Patient Association nutrition checklist.
Thanks, Gemma. Yeah, hi everybody. I'm Eleanor Coleman, and I'm a researcher. I work for with Gemma on the First Insight team, and also in different organisations in Cardiff University. So as Gemma says, I'm going to describe the design of the first evaluation of the checklist implementation in the Scottish Borders. So that'll be the first few slides, and then I'll go on to describe our findings of the evaluation. Okay, so the aims of the evaluation were to understand and evaluate the perceived impact of the checklist on 3 different groups of people. So firstly, the older adults who received the checklist. Secondly, who we call the implementers. So these are the staff who were completing the checklist with older adults. And then finally, staff, so mainly managerial staff in the social care, housing and voluntary sector organisations that we were working with. We also wanted to understand the feasibility of the initial rollout of the checklist, and wanted to assess how successful implementation of the checklist was in the community setting. Finally, we then wanted to understand how best and whether the checklist should be rolled out further, and we wanted to inform any future implementation and strategic inclusion within the organisations, but in a broader geographical area. Okay, so these aims were addressed by the following objectives. So the first objectives was to explore the barriers and facilitators of implementation of the checklist from the perspectives of the implementers, so the staff completing the checklist, and staff within the organisations. We wanted to evaluate the feasibility of implementing the checklist in different organisational contexts. We wanted to explore how the checklist may or may not achieve its outcomes, and this is if this was different to what we thought. So at the end of the evaluation, we wanted to see if the mechanisms through which the checklist works, which was described in by Gemma in the logic model, we wanted to see if that was how the checklist produced any outcomes, and then also we wanted to make any necessary changes to the logic model depending on our findings. We also wanted to assess what the costs were for delivering the checklist in the organisations involved in implementation. And then finally, we also wanted to assess whether it would be possible to use routinely collected NHS data to measure outcomes in any future research projects in this area. So this type of data is data that's collected for everybody and can be assessed directly from records held for an individual, rather than having to collect the data from the person themselves. So our evaluation had originally aimed to explore outcomes and experiences from the older adults themselves who were in receipt of the checklist. However, this was unfortunately not possible due to a lack of referrals of older adults to the research team, but I'll go into more detail about that later. And so the use of routinely collected NHS data could be useful in these circumstances where there are barriers to collecting the data directly from participants. Okay. So what methods did we use in the evaluation? So the Eat Well Age Well delivery team collaborated with the Scottish Borders Health and Social Care Partnership to identify potentially suitable organisations within social care in the third sector. And Jen discussed that a little bit earlier. So a total of 16 organisations were identified, and key contacts within the organisations were approached by Eat Well Age Well staff. A total of 4 organisations were unsuitable to implement the checklist because of capacity issues or because this type of work didn't fit well within their remit. But 12 organisations were recruited and trained by Jen to implement the checklist with older adults who were on their caseloads. So we then used a mixed method design, collecting both quantitative and qualitative data. We collected, as you can see on this slide, we collected pre and post training evaluation surveys, and these were completed on Google Forms by implementers who were retaining the Eat Well Age Well training. The survey was designed by Eat Well Age Well and contained questions on the implementers' knowledge of dietary needs, how confident they were in identifying malnutrition in older adults, their knowledge of available signposting to malnutrition support, their knowledge of screening tools, and confidence to use the checklist in their existing job role. We also collected operational data, which as you can see is a second blue box. And this was completed by organisations who were implementing the checklist. So this data included, so once the checklist was being implemented, the organisations would report the number of older adults with which the checklist had been used, and this would be broken down by age and also the number of older adults who were deemed at risk of malnutrition or in need of nutritional support. And then also the number of older adults who were referred for additional support. We also conducted 8 semi-structured interviews with both implementers and organisation staff. We invited staff to take part through invites distributed by the key interviewees' perspectives on the barriers and facilitators of using the checklist, including their views on the training and delivery of the initiative and the perceived outcomes of using the checklist, how well the checklist fitted in with their usual practice, and the strategic fit of the checklist within their organisation. to supplement the data that we collect in the qualitative interviews, and also to have broader reach with more members of staff within the organisation, we also collected responses to online surveys, in which we asked really similar questions, but just allowed more people to respond to us. And we collected this with 38 staff members in the organisations who were implementing the checklist. As you can see, we also interviewed Jen, the Eat Well, Age Well trainer. And as I've discussed already, we collected data on the cost of implementing the checklist, which we then used to calculate the approximate cost of implementing the checklist across the organisations. And we used some internet searching and contacted key contacts within the Scottish Border to identify what routinely collected NHS data may be used in future research. So we then analysed the interview and online survey data thematically, analysed the quantitative data, and then we combined all of the data sets in a triangulation exercise and mapped findings onto our research objectives. Okay, so then what were the findings? So next slide, please. Thanks, Jen. Okay, so I'm going, the next few slides are the findings from the evaluation. So the first was, what were the organisational context? So how did the organisations differ? So the organisations varied in terms of size, the settings, and also the services that they provided. So organisational caseloads were prone to fluctuation. So organisations described that they didn't have a set number of older adults on their caseloads, and it did vary from time to time. And for each organisation, the caseload ranged from less than 10 older adults to in other organisations over 200 older adults. So the organisations did differ. The services provided to older adults were either well-established services, but some were relatively new and had been set up within the previous year. The services that were provided varied across organisations. So organisations provided both acute and long-term support to older adults. Older adults were seen by staff in their own homes, in assisted living accommodation, or in community settings such as social centres or transport. And the services that were provided included assisted discharge from hospitals, personal care, assistance preparing food or meals and shopping, assistance accessing appropriate financial support, meal services, befriending services, opportunities for social interaction, such as organisation of community social groups, and operating transport services. So there really was a wide range of services that were provided to older adults. Okay. So the roles of the participants who took part in our interviews and online surveys. So those that took part in the interviews varied slightly from the staff that took part in the online survey. Themselves as having mainly senior or managerial positions within the organisation, and most were also in contact with older adults as part of their job role. Interviewees described how they had extensive experience, some for decades, of working with older adults. However, the length of time in their current job varied from a few months to more than 10 years. So for the survey participants, examples of the types of job roles included support or community link workers, coordinator roles such as local area coordinators or sheltered housing coordinators, hospital liaison roles, dementia advisors, and then also managerial or administrative roles. The majority of survey participants worked in a position where they came into contact with older adults. That was 68%. And around a quarter of survey participants line managed member of staff who came into contact with older adults. And it was only a couple of survey participants who didn't come into contact directly or line managed, and members of staff who came into contact with older adults. And then, as I mentioned earlier, we also interviewed Jen, who trained the implementers on using the checklist. Okay, so next slide, thank you. So we wanted to establish what the usual practice was with regards to malnutrition in the organisations that we were working with. So trainees were asked to rate their knowledge of malnutrition when they attended the training session with Eat Well, Age Well. So 92% of trainees reported that their knowledge was adequate or good, and only 8% reported little knowledge of malnutrition. The majority of interviewees also reported that they felt confident dealing with concerns. However, 38% of trainees reported that they were not confident spotting the signs of malnutrition. Interviewees described how they had established processes regarding malnutrition in their organisations, and that they work closely with social services. Participants described already referring older adults who they were concerned about to the GP, district nurses and dietitians. However, there was mixed existing practice regarding nutrition. So some services had regular reviews with older adults, which included a nutritional assessment. However, others highlighted concern that no nutritional support was included in their current practice. There was also a lack of in-depth training regarding malnutrition. So 84% of trainees who attended the Eat Well, Age Well training had not received malnutrition training, and only 10% of trainees were previously aware of screening tools to identify malnutrition. Okay. Okay, so this finding this slide is just going to discuss the findings with regards to use of the checklist. So the training to support implementation of the checklist that Jen delivered was delivered to 169 implementers in 12 organisations between September 21 and August 2022. So of the 12 organisations, 7 organisations provided operational data, which gave an insight into the level of implementation of the checklist within those organisations. The checklist was used with a total of 461 older adults from October 21 to November 22. And the number of older adults that each organisation used the checklist with ranged from as little as 3 to as many as 238 in one organisation. And of the 461 adults that the checklist was used with, 7.4% of these were identified as at risk of malnutrition. However, some organisations reported that they were implementing the checklist, but they did not return operational data to Eat Well, Age Well, and therefore the actual figures may have been higher than what we've shown here. The organisations also took an average of 3.5 months to return the operational data following attending the training with Eat Well, Age Well. So some organisations attended the training and seemed to get started straight away, whereas other organisations took up to 7 months after the training to start checklist implementation. Implementation methods varied across the organisation. So while some organisations completed the checklist with all adults that they contacted, others only completed the checklist with older adults that they had concerns about regarding malnutrition. And this was contrary to the advice provided by Eat Well, Age Well, which was to use the checklist with all older adults that they came into contact with. So the survey participants and the interviewees described reasons that they didn't use the checklist, and these included that it wasn't appropriate in the setting or with a particular individual, or that they hadn't received appropriate support from their organisation to implement the checklist. Okay. So interviewees and survey participants stated that the checklist was easy and quick to use, so taking between 5 and 15 minutes on average. In the implementation period, 34 older adults were deemed at risk of malnutrition and were provided with advice. Of these 34 older adults, 7 were referred to additional support services. So 5 to the GP, 1 to a dietitian, and 1 to a social worker. Jen, the Eat Well, Age Well trainer, who's a registered dietitian, also provided advice on referral pathways and gave tailored advice for specific individuals when this was necessary. Participants were asked to describe what signposting methods were available to refer an older adult to if an older adult was deemed at risk of malnutrition. And these included providing advice to the older adult or family friends and carers, or referral to GPs or district nurses, the Food Foundation, or social care. Okay, so interviewees and survey participants described how the questions in the checklist were personal and how trust and rapport between a staff member and the older adult facilitated implementation of the checklist. They also mentioned having longer appointment times allowed implementers to explore any concerns without feeling rushed. The participants described how practical strategies such as providing paper copies, which were more easily transported between appointments, were considered facilitators to implementation, and incorporating the checklist in routine reviews for older adults was considered a facilitator. And one interviewee also described how their organisation had incorporated training of the checklist training into new staff members' general induction, and described how this maintained momentum for implementation. Interviewees also suggested that how often they came into contact with older adults allowed them to identify signs of malnutrition easily. So, for example, if implementers contacted older adults sporadically, they were able to notice differences in the older adult's appearance more easily than someone who was in daily contact with their older adults. And also, if implementers worked in community social group settings where food was provided, they had opportunities to identify whether older adults were eating or not. Okay, so what were some of the barriers to using the checklist? So participants described how use of the checklist was not appropriate with some older adults because the older adults were considered vulnerable, were unable to comprehend or answer the questions, had dementia, or if they had or if they'd provided a family member with power of attorney. Alternatively, some interviewees described how they had no concerns regarding malnutrition with the specific older adults that they came into contact with, and therefore using the checklist would not be appropriate. Some participants considered that the questions asked would be considered as intrusive or offensive by older adults, and also that it wouldn't be appropriate to ask them the questions in front of other family members. Participants described practical challenges such as not having sufficient time with older adults at appointments due to hectic workloads, or not regularly using the checklist and becoming de-skilled. Sometimes use of the checklist wasn't suitable, such as in community settings where there were no private spaces that could be used, or for example, with drivers who were providing transport services. Some interviewees described that existing malnutrition referral pathways were well established within their organisations and that they were already signposting to other services, and so felt that although the checklist was great, that they were already doing what the checklist was advising. And then finally, the impact of the COVID pandemic was a barrier to implementation of the checklist, as you can imagine. So there was a reduction in face-to-face appointments with older adults, and then also a lot of the community social groups were withdrawn. And then even when face-to-face visits resumed, lots of older adults were very wary and not comfortable with home visits or attending the social groups. Also, the COVID pandemic caused major resource challenges to the organisation due to staff and volunteer absences. Okay. So there are a number of positive outcomes from using the checklist in organisations. Interviewees described that providing older adults with low-level intervention, as described in the checklist, resulted in perceived health improvements for the older adults. Using the checklist also improved practice, so participants described how they had improved skills and confidence managing malnutrition. They also described how the checklist allowed them to document cases of concerns, and that this detail could be used during the referral process to other health and social care professionals. And this in turn facilitated improved multidisciplinary working. Also, one interviewee described how the checklist would be looked at favourably by the Care Inspectorate Scotland, which is a health and social care scrutiny body. And finally, survey participants asked if they thought using the checklist would impact older adults positively, and 86% felt that it would have a positive impact. Okay, I'm just looking at the time, so I'm going to try and speed up. So how much did the checklist cost to use? So we did ask interviewees about details of the associated cost of using the checklist. For the training costs, there weren't many costs associated with this because most of the training was done online, or if it was done face-to-face, it was in an organisation's room on site. An average of 8.5 staff members attended per session, and so using health and social care costs, each training session would cost about £115.33 per support worker per manager. Attendees were also provided with training packs, and these cost an additional £4.50. However, delivering the checklist itself was very quick to do. As I've mentioned earlier, it cost between 5 and 15 minutes, and so that works out at £4.17 for a support worker or £6.83 for a manager. One interviewee mentioned that if they had to complete the checklist, they would do a separate home visit, which increased the costs if that did happen, because it would take longer, and you can see that on the slide there. Okay, so most interviewees said continued use is likely when we asked about the likelihood of continuing to use the checklist within their organisation. And 57% of survey respondents reported that the checklist would continue to be used, or would be used if they hadn't used it already. 38% were unsure whether to answer how they would answer that, and only 5% thought that the checklist could not be used in their organisation. Most survey respondents reported that the checklist fitted in well to their usual practice, and also with the wider work of their organisation. There are a few recommendations for continued rollout. These included level, having physical paperwork, reminders to staff, and then also a refresher training session from Eat Well, Age Well. Okay, so just to conclude, so the findings from this project suggest that the checklist was acceptable to most organisations, and that the implementing staff mostly understood and valued the aims and importance of the checklist. The staff also valued that the checklist was easy and quick to use. The outcomes for organisational staff included increased awareness of malnutrition and improved skills and confidence to identify malnutrition and provide advice or signpost to additional support. The checklist had perceived positive outcomes for older adults, including improved health following receiving first-line advice. However, the checklist was not implemented as planned in some of the organisations, so it wasn't used with all older adults that were on the organisational caseloads. And as described, there were workload and resource issues due to the COVID pandemic, which affected implementation. And it therefore may have been prudent to delay the evaluation until implementation had been more established in the organisations. One thing to note was that the number of older adults deemed at risk of malnutrition was slightly lower than what we were expecting at 7%. And finally, further work is needed to assess the impact of the checklist on older adults themselves. And what we have suggested is this could be potentially done by using routinely collected NHS data. Okay, thanks very much. I'm just going to pass back over to Gemma, who's going to answer any questions that anybody has.
I should unmute myself. Thank you, Eleanor. So this final slide is just to say a massive thank you to everybody who's supported this piece of work, in particular the 3 public contributors that were a huge part of the design of the evaluation as well as interpretation of the results. All of the project team, you can see everybody's names on the screen there, as well as to thank all the participants from the organisations that gave their time to take part in the research. And you can see at the bottom there is just our acknowledgement of the funding from the NIHR. And the final slide has, yes, invitation to you to ask any questions or anything further you'd like to discuss, but also that link that I said where our full report is, that you can get all the ins and outs of what Eleanor's been talking about, the full image of our logic model and anything else you might need. But thank you.
Lovely, thank you very much. We've got a couple of questions that have came through. So we've got one here that was just asking if there is any kind of evaluation tools that can be shared. Anything that can be sort of helpful maybe to people doing similar work or things like that?
Yeah, I think so. We were looking at quite a lot of different evaluation tools, in particular to evaluate outcomes for older adults, which we didn't end up using, as Eleanor explained. There was a few, capacity issues with actually recruiting older adults into this project. But if anybody would like to look at those kind of the tools that we identified in that process, because we did spend quite a lot of time on that. So there's a few things that were identified as being both useful measures and also that would be sort of feasible to complete. So we haven't put our email addresses on this slide, but I think they are available on that link, or if you just search our names. So if you want to pop your email address in the chat, we can either email you, or if you want to email us, we can definitely send those evaluation tools. If we're thinking more about evaluating the implementation, again, we'd be happy to share some of the questions that we explored both in the interviews and in the survey. And then Jen, whether you're you obviously have the survey questions for the evaluating the training outcomes as well. So yeah, we're happy to share any of those things. I see Eleanor's put her email in the chat, but I can put mine in there as well.
Yeah, I'll also, when we send the video around, I can put everybody's kind of contact details in that as well, so that people can get them. Lovely. The other question I have was actually, it was emailed in ahead, and it was just asking if there had been sort of any indication that a kind of particular service or organisation was better suited to using a checklist. Or using the checklist, I should say.
Well, I guess there's kind of a little bit what Eleanor's just been talking about in terms of where there were particular facilitators to using it, or conversely where there were barriers that maybe things weren't so appropriate or relevant, but in particular where people had sort of there was, I suppose, a combination between it sort of fitting into the person's existing work and being the kinds of things that the sorts of things that somebody would do in their practice. So the person was used to being asked questions, but also I think a key thing was where it could just be embedded into what the organisation sort of, depending on what the organisation is, but the sort of regular conversations or processes that the organisation would have. Maybe the first time that they saw somebody, and it would be sort of part of a battery of things that they would go through, or as part of a regular checkup or that sort of thing. I suppose it's very difficult when it's in an organisation where you might just see somebody once, and it's hard to fit into that one contact, and then you're not going to see them again. That might be a little more tricky. So I don't know if you'd add anything to that, Eleanor, in terms of your sort of analysis of the data.
Yeah, no, I was just going to say exactly what you said, Gemma, that lots of the organisations where it seemed to work really well were when they had monthly reviews or regular reviews with an older adult, and that's when it worked particularly well. But yeah, I described some of the organisations where there were challenges. So a lot of the community settings, there were challenges because the workers just didn't feel that it was appropriate to use. So yeah, just repeating what you said, Gemma.
Thank you. And then our next question here is just asking what you see as next steps for this.
I don't know if Michael, if that's a particular, well, I suppose there's a question about next steps more generally, but also next steps within Scottish Borders specifically. And I think generally it'd be interesting to sort of have discussions about the ongoing sort of rollout and implementation, as Eleanor mentioned, how that might be further evaluated as it continues, and how we might do that in a really streamlined way that makes it sort of an efficient piece of evaluation, but also thinking more broadly about how to best support implementation in other places if people want to take that up. But yeah, I'll hand over to Michael in case there's anything in particular you want to say about in Scottish Borders specifically.
Specifically in Scottish Borders, I think the next step is, now that the evaluation is complete and we have the outcomes, is kind of communicating that to kind of strategic managers and the kind of across the partnership, particularly kind of the strategy planning group arm of the IJB, the Integrated Joint Board, because I think kind of part of the delivery mechanism was people chose to opt in. There was no strategic direction given, so I think kind of that kind of exploring what strategic direction we would give to kind of commission services as to the use of this. To sort of raise the profile of malnutrition in older people as a real and present issue, and we should be addressing it and setting out in a strategic context would be the next step. So it's kind of about communicating it and setting out in a strategic context would be, from my perspective, the next steps. I suppose the conversation also has to be with Jen about how do we continue the kind of the rollout. Is there more organisations that we can be looking at to kind of who would want to opt in, and also the maintenance of the existing organisations, kind of to keep using the organisation. And there's certainly kind of elements of kind of setting out in a kind of digital context. It's something we touched on but never really bottomed out in our evaluation. Is it's setting out in a kind of into embedding it into some of the technology we have. All the home carers through use Total Mobile as a system, so they get all their instructions, all their visits. Can we embed it into that as a kind of as a function that any home carer could kind of use? And also kind of all the social workers are now getting iPads with all their kind of assessment tools on it to take out to record it. Could it be embedded in that? So there's that exploration of the digital aspect to it as well.
Yeah, and I think certainly from our point of view in Eat Well Age Well, this is what we're always really keen to be doing. So we're always looking at new ways that it can be rolled out across Scotland as well, into kind of different health and social care partnerships and organisations like that. And I see in the chat there, we've got Amy from Borders there who's saying in their podiatry team who see high risk foot patients on a regular basis, they've been completing the checklist a few times over the past year, which is helping to highlight the importance of nutrition and wound healing. So it's great to see that it's a lot of different ways that people can take this work and can take things like the checklist to improve the work that they are doing and kind of highlight it there, which is always very nice. Lovely. So I think, let me just double check to make sure there's no other questions came through there. No, I think that's it coming through, and it's very nicely timed that that's just gone just about 1 o'clock. So I will just take this opportunity to excuse me, I'll just take this opportunity to thank everybody for coming along, and to thank Michael, Gemma and Eleanor for speaking today as well. It's been a really interesting project, and it's been great to get it kind of evaluated and get the help and support with that as well. So we'll get the kind of recording out and a wee email around to everybody that's came. But if there's any more questions or anything that you might have that you want to chat with us, do feel free to reach out once I send the links and things around.
Thank you everybody for the nice comments in the chat. Great that you could attend.